So, good morning, good afternoon, and welcome to the fourth webinar in the Health Systems Impact Modeling Consortium series. I'm Zubin Shroff from the Alliance for Health Policy and Systems Research, and I'm pleased to welcome you to today's session on WISE-Ethiopia, Workforce Information Systems and Supply Chain Optimization to Strengthen Primary Healthcare in Ethiopia. And this webinar is part of our broader effort to bring together researchers, policymakers, implementers, and development partners who are interested in understanding how modeling can help us better understand and improve health system interventions for stronger health systems. We are especially pleased to have colleagues from Ethiopia and the University of North Carolina with us today. And we seek to not only discuss the technical modeling work, but also, as many of you, those of you who've been attending this webinar series, to discuss its policy relevance and practical use. Could I have the next slide, please? So just an overview of the session, we will start with the rationale for the Health Systems Impact Modeling Consortium program of work, why the Alliance is invested in this area, and how this webinar series fits into a wider community of practice that we are developing as part of this program. We will then move on to the main presentation by Atalay, Mulu, and Professor Sachiko Ozawa, who will present the WISE-Ethiopia project and its emerging work on supply chains, information systems, workforce, and modeling for primary healthcare. We will then have a panel discussion, question and answer session. We will be joined by Dr. Israel Toro and Professor Tim Robertson, who will also be part of this. And then Tim Robertson will provide some closing reflections. After the panel, we will have, of course, opportunities for question and answers with all of you. So could I have the next slide, please? So the basic motivation is quite simple, that health system strengthening is widely recognized as essential, but we struggle to quantify how investments in health system interventions translate into changes in service delivery, health outputs, and ultimately health outcomes. This is especially important at a time when countries and partners are making difficult choices about priorities, resource allocation, sustainability, and resilience. Could I have the next slide, please? So the consortium really aims the overall objective was this, to better measure the impact of investments in health systems interventions on improvements in service delivery, health outputs, and health outcomes. And this is to help those within ministries of health, those working in health systems, to make the case for increased budgets for health systems, and for those working for ministries of health themselves to make the case for greater investments in health systems with ministries of finance. And at the global level to make the case with global health initiatives for greater investments in health systems. So the aim was really to nurture the development of health system modeling approaches and techniques to understand and measure the impact of health system strengthening interventions on the provision of essential health services. And another core objective was to lay the foundation and support learning ecosystems in countries of policymakers, researchers, and development partners to bring them together into a conversation so that the modeling is not an academic exercise, but is a tool to inform policy and program decisions. So there are two main components of this. The first, the country modeling studies. There's another project in Ethiopia that I'll just mention briefly, Indonesia and Kenya, sorry for the typo here. And then there's a global community of practice, which Health Systems Global and the Alliance are working on together, which this webinar series is a part of. Could I have the next slide, please? So the country model, this slide really illustrates the kinds of questions that we're addressing with the country studies. So in Ethiopia, we're working in the Amhara Public Health Institute to understand how interventions around CBHI coverage, fee waivers, and reimbursements shapes treatment and effective control for NCD patients using a system dynamics modeling approach. In Indonesia, the AMHAS project, Assessment and Modeling for Health System Strengthening, focuses on understanding how changes around drug supply, task shifting, and referral patterns can improve the quality and actually outcomes in terms of diabetes and hypertension care. And in Kenya, the project examines the role of community health promoters, who are paid community health workers, looking at how changes in the numbers of these workers, their training, and drug supplies may influence service delivery at the community level. Now, two of them, these three studies look at NCDs. Two of them use a system dynamic approach. One of them looks at a cascade model. But the common thread is really that each study begins with a country relevant health systems question. It was required that the country teams really engage with policymakers and development partners, and we organize a country consortia which actually guides the studies in each country, and then uses modeling to make the consequences of different intervention choices explicit. Could I have the next slide, please? So a key priority is to ensure that the modeling outputs are usable by policymakers. So we're looking at, we got a lot of feedback from this consortia to understand what products would be useful for them. Many of them mentioned the need for dashboards. We're developing things in language that is less complicated than modeling often tends to be, to help to inform policy and practice. We're also working on a supplement series in health systems and reform, which will consolidate the methodological progress we've made through these country studies and reflections from across the country studies. And we're also planning a satellite session at Health Systems Research Symposium 2026, which really will discuss what we've learned from the project so far, how we've shifted the needle in the 3 years that we've been doing this, and what does this mean for the health systems research community. Could I have the next slide, please? So the community of practice is the second component, and this really, the webinar sits in this space. The goal is to create a space where people working on health system modeling can discuss their current work, share challenges, and build a broader appreciation of what modeling can do, and also importantly, what modeling cannot do. And this is important because the field is still emerging. There needs to be a shared language between modelers and health system researchers, and between researchers and policymakers. This is what we're really encouraging through this space. We have the encouraged knowledge sharing through these webinars. As I said, this is the 4th webinar. We also had a linking and learning session, which is more in the form of a discussion. And we're creating a repository, which is a database around resources on health systems modeling. Could I have a next slide, please? So this slide shows some of the activities that are underway and have been already carried out. So we had webinars on the AMAS project, which I mentioned in Indonesia, supported through this program of work, on the long-established Tanzila on-say model from Malawi, which Professor Tim Hallett spoke on. We had a linking and learning session with Professor Stefan Berge from Harvard University on his perspectives on what modeling can and cannot achieve. And we more recently had a webinar on participatory systems dynamics modeling for cardiovascular outcomes, a multi-country study led by Swiss Tropical Public Health Institute. Could I have the next slide, please? So with that framing, I'd like to now introduce the speakers for the WISE project. So Professor Atalay Mulu is an assistant professor of clinical pharmacy at Addis Ababa University. He has more than 10 years of experience in hospital service, teaching and research in Ethiopia, and serves as co-PI of the WISE-Ethiopia project. And with him is Professor Sachiko Ozawa, who is Vice Chair of Research at the University of North Carolina in the United States. Her work sits at the intersection of pharmacy and public health, and she is a co-PI and modeling lead for the WISE-Ethiopia project. So over to the both of you for the main presentation.
Thank you so much, Zubin. Can you hear me?
Yes, you're audible.
Okay, is my slide visible?
We can hear you.
Yes,
Okay.
yes,
Yes,
yes, it is.
we can see.
So yeah, thank you so much for giving us this opportunity to present our project, share our experience. So it's really, it's a pleasure being here and then present our WISE-Ethiopia project. So this WISE-Ethiopia project is led by Professor Tafari Gaddef. Unfortunately, today he's unable to join us. And then we have also from the beginning, from the project inception, to individuals from the Ethiopian Ministry of Health were part of the project, starting from the inception. One is who is responsible for the supply chain aspect of the Ministry of Health or department of the Ministry of Health, and the other is responsible for the primary healthcare components of the Ethiopian Ministry of Health. So from our literature search and then from our own day-to-day practice and then experience, we know that the supply chain in general is weak in Ethiopia because of different multiple actors. So one of them is like we are really implementing the siloed information systems which are not interoperable, and then fragmented means like they're not really implemented across the healthcare system. And then there is also misaligned workforce. So our solution is like if you optimize the supply chain, information system, and then workforce, will impact the availability, affordability, and then quality of medicines across the primary healthcare system through reducing the shortage and then wastage, and then improve availability. And then this will have also like a subsequent high-level impact on the healthcare system. So with this, our project have three major aims. The first aim is to undertake an in-depth analysis of the supply chain, information system, and then workforce. This is primarily to generate evidence for our model assumption. And the second one is utilize modeling to improve availability of essential medicines, reduce wastage, and then leakage. Of course, the last one is to strengthen the South-South collaboration and partnership towards modeling. So our project is a 5 years project. So we started in June 2024. We are almost at the end of year 2. So it has 3 major phases. The first phase is purely dedicated for evidence generation for our modeling activity. And then the second phase is applying modeling and simulation, at least developing training, and then probably calibrating our modeling assumptions. Initially, our assumption was to use agent-based modeling, but later on we found out that agent-based modeling may not address the all dimensions of the supply chain, given the complex nature of the system. So as a result, we are going to implement or apply system dynamics in the agent-based modeling. And then after that, our phase 3 is implementation phase. We will pilot implement our project, and then the implementers are going to be the Ethiopian distrophiles, and then we are going to implement it on selected primary healthcare units in Ethiopia. So as part of our phase 1 activity, we did an in-depth qualitative study to understand the determinants of the primary healthcare supply chain performance. We included a total of 41 key informants, those from the primary healthcare facilities, that means frontline healthcare workers, representatives from the World Health Office, that's the one that's responsible for actually primarily administering these primary healthcare units, and then third is Ethiopian pharmaceutical supply services house, that is the government procurement agency that is responsible for supplying these primary healthcare facilities primarily. And then we studied in 3 major regions: Amhara, Oromia, among the developed regions, and then Somali region among the developing ones. So accordingly, we found out that key informants perceive that still there is a supply chain problem across the primary healthcare continuum, and then they describe it as the EPACS, which is the primary supplier of these primary healthcare facilities. The filling rate is between 15 to 40%. That means, like, you can imagine, like, primarily you are expected to acquire medicines from EPACs, but if the filling rate is for up to 30%, you can expect like how the availability is going to be ensured through this system. And then in addition, there is also a significantly, high lead time, like up to 3 months. And then particularly if the medicine is supplied through the World Health Offices, that's going to be actually the main delay for medicine supply. And then they also perceive that there is still a longest actually reported stock outs. So accordingly, we thematized the key determinants into 3: policy level factors, operational factors, and then contextual factors. Regarding the policy level factors, yes, as a policy, the primary healthcare facilities are expected to, procure only from the EPSAs, the government procurement agency, unless otherwise they got approval from EPSAs, they can't procure medicines from other private suppliers, for example. So this was actually mentioned as both a barrier as well as opportunity. As a barrier because it restricts in accessing medicines when at times of actually stock out. But as an opportunity, the EPSAs is one that actually supplies products in affordable price. The second policy level is like sort of structural misalignment because the World Health Office is the one that's responsible for securing or financing the healthcare system, the primary healthcare units. And then at the same time, there is still misaligned or actually not similarly implemented across different regions. That some of the times, like the World Health Office is the one that directly supplied, but sometimes the EPSAs is also supplying these medicines directly. So this sort of misaligned procedure actually created delays in acquiring these essential medicines. And then the other is recently, because of this issue, the Ethiopian government, through its EPSAs, they recently established the Committed Demand Initiative. Means, so previously EPSAs was reporting that they are significantly actually facing wastage through expiry because the quantified medicine as well as forecasted and quantified medicine is not actually reflecting the demand. So because of that, the facilities were not committed for those for the forecasted or the requested amount. So as a result, this committed demand initiative arrived at least to make the primary healthcare facilities or any facility in Ethiopia responsible for any wastage or shortage for the forecasted items. And then the other is previously there was a continuous supportive supervision, but they reflected that this sort of supportive supervision is significantly declining because of different factors. The second one is the operational factors. So in our country, in our context, the Drug and Therapeutics Committee is the one that's responsible for selecting essential medicines for each facility. And then at the same time, the quantities, budget, and then everything is going to get approved by these Drug and Therapeutic Committees. But unfortunately, this committee is not functional across different levels. So this was also mentioned as one of the operational factor. The fragile financing system. Yes, Ethiopia recently implemented a community-based health insurance system, but health facilities are not reimbursed in full. And then even if they are reimbursed, so they are not reimbursed timely. So this actually created a difficult, budget. The facilities are really constrained in terms of budget and the like. And then the other is the misaligned workforce. Particularly, the participants reflected that there are sort of non-specialist placements. And then there is also high turnover at remote sites. Usually people prefer to work in relatively better cities or developed cities than working in remote cities because of different, personal issues or preferences. So this actually created lots of inconsistencies across the primary healthcare system. And then the last one is usually the forecasting and quantification in general, the supply chain management is the documented. They're applying the paper-based information system that creates actually lots of inconsistencies. The last one is the contextual moderators. Usually the particularly recent times, the insecurity, poor road access was one of actually the major determinant that created actually even reason for stock out as well as reason for high lead time or longer lead time. And then the other is like the WHO, the Woreda Health Office mediation distribution is also one of the barrier and then considered as a contextual moderator. Market volatility is also another issue that was repeatedly mentioned by participants, that the budget is probably increasing, maybe maximum up to 10%, but the medicine price is significantly increasing up to 50%. Then you can imagine how this significant increment of inflation, or whatever you call it, like medicine price, will have impact on the general healthcare financing or the finance of the healthcare facilities. Unpredictable donor support. And then the last contextual moderator was substandard storage of medicines, because by principle we want to make sure that patients are accessing quality medicines, but if the medicines are not properly stored, you can imagine the quality of the medicines accordingly. The second one is, in addition to the qualitative study, we also do a survey, a cross-sectional facility survey, and then we surveyed a total of 56 primary healthcare facilities using 25 tracer medicines for primary hospital and health center, as well as 8 for health posts. This is actually the tracer medicines that are approved by the Ethiopian Ministry of Health to measure or monitor the performance of the supply chain system in Ethiopia. So here, almost similar findings were emerged. Like we can see that tracer medicine availability ranged from 9.5% to 100%. And then the manual inventory accuracy is significantly lower than the digital system inventory accuracy. That was actually reflected by the qualitative finding. And then none of the health posts have actually functional computer as well as the internet. So means we can't implement digitalization in the units. And then some of the tracer medicines were stocked out even nearly a year, like gentamicin, amoxicillin, even if they are mentioned as tracer medicines. So that's also another finding in our survey. And then the wastage rate, medicine wastage rate, was relatively higher amongst the program medicines as compared to those medicines sourced through revolving drug fund. So accordingly, like there is capacity in the skill mix misalignment in terms of the workforce. We found out that particularly, most of the workforce are not trained. At least they didn't receive post-deployment supply chain related training. The digital infrastructure is still very weak, even if primary hospitals, even if the numbers are not representative, because we only include 3 primary hospitals in the 3 regions. So all of the primary hospitals have functional computer in the internet access, but health centers have only 56% of them have a functional computer, but none of the health posts have functional computer and internet access. And then in addition, like in principle, facilities are expected to implement this electronic logistic management information system, either through DAGO2 or district health information system 2, but only 23% of them are actually implementing it. And then, of course, the inventory accuracy is also very poor for those facilities who implemented paper-based information system. And then in terms of storage and logistics, still there's a huge gap. And then in addition, like we also studied the pricing and then affordability of medicines between medicines like that were actually sourced through the government procurement system, as well as in the private sector or in the private facilities. And then we found out that there are still medicines that are not affordable as per the WHO HAI definition. That, for example, to metformin, it requires 7 days of the lowest government worker wage. So here, when it comes to the private sector, for example, for amlodipine, it's affordable in the public, but if it's sourced or accessed through the private sector, so it's not affordable as per the WHO definition. Similarly, iron folic acid. So there are, we assessed actually all the tracer medicines affordability as per our initial assumption. And then in addition, we know that there is misaligned workforce, and then we wanted to study like how many of working days as well as times really dedicated or maybe implemented in value-adding activities. And then we found out that particularly the health post employees, so more than half of actually their time is wasted on non-value adding activities, means so they're not doing anything related to the healthcare service, as compared to 42% in health centers and hospitals. So majority of these non-value adding time are because of the system induced, not not like individual specific absenteeism and then failure, but instead it's because of the system failure. So the idle time was a predominant system-induced factor, and then only small amount of time is really dedicated for the actual value-adding activities. So if you look at on the graph, we clearly see that particularly those participants from the health center and the primary hospitals, so at least relatively higher number of their time was dedicated for supply chain and logistics activities as compared to health post participants. That health post participants are actually dedicating only 2% of their time. So as a solution, we know that there are different gaps. So our solution was, if you do modeling and simulation, probably we can partly solve the problem. So through this, I will hand over the next part to Professor Sachi. She will take us through the previous experience, lessons learned from our modeling and simulation activity, and then way forward. Professor Sachi, over to you.
Thank you very much, Atalay. So we were trying to build on past modeling experiences in order to figure out how we would do so in Ethiopia context. We've previously built 3 different kinds of models. They were all agent-based models that were looking at the impact of substandard falsified antimalarials in various countries in Africa. Another one was looking at antimicrobial resistance and how to model that. And the final one was trying to do more work around economic evaluations of medications and applying that. And each of these were, again, based on an agent-based model to try to optimize different policies to figure out what the impact of all of those would be. So for this activity in Ethiopia, we are trying to build a model so we can optimize the primary healthcare supply chain, representing different medications and the different heterogeneous actors to look at the impact on local rules and decision-making. So what we've learned from past modeling work is the following 3 things. One, it's really important to involve policymakers from the start in modeling. And so we've done that with this project involving different parts of the Ministry of Health. Another point is to need to gather relevant local data. And oftentimes in low and middle income countries, in order to do modeling work, you really need to gather data in order to make the model relevant and timely. So we spent the first 1.5 years trying to gather data that would inform the model. And third, there's a lot of policy relevance of capturing variability across geographic areas, populations, and medicines, and building an overall country-level model without that detailed variation to be able to kind of capture that heterogeneity may not be as relevant. And so we wanted to try to gather this data so that policymakers can really understand what's happening on the ground and keep them involved. So here's our lovely current model, which is a little hard to read, but hopefully I can walk you through it. So the main portion is going to be an agent-based model. And then we're supplementing the rest with a system dynamics model. And the reason why we did so is because we wanted to really get at that heterogeneity, the variations that exist by medication on wastage, shortage, and leakage of different medications. And so that is represented by the agent-based model, where we actually have the different tracer medicines that Atalay was talking about earlier from the survey. And so a lot of that data will actually go into the agent-based model. And then we have the system dynamics portions. You heard earlier that this project is also looking at information systems, human resources, and financing, as well as the population impact of changing some of these policies. And so those are the portions that actually become a system dynamics stock and flow changes over time. And we were setting it up that way because we're not collecting as much data on the information systems, the human resources and financing to be able to run a really complicated agent-based model for everything. But we wanted to focus the agent-based model really on the medication because our goal is to look at supply chain optimization, but make sure that we're incorporating all these other things, such as the budget on the bottom, or the information system and human resources at the top right of this figure. So the goal here on the right, you see the wastage rate, the percentage availability, and the leakage rates. These are our different outcomes that we're trying to optimize. And I mentioned briefly that there's also going to be this component of the population impact of improving the supply chain. And we wanted to make sure we're incorporating that for policymakers, because we believe it's really important for them to be able to say what they've achieved by optimizing the system. So we have the number of reduced wastage, more availability, leakage, as well as the number of deaths and survival and better treatments that are given because we've optimized the supply chain. So those are the different outcomes that we're tracking, that we're hoping to track within the model. So our modeling approach, we're using real-world evidence from primary healthcare in Ethiopia, and we're tracing different tracer medicines through the supply chain and capturing the heterogeneity using an agent-based model. And we're also trying to incorporate the health and economic impact of this wastage, shortage, and leakage, and we're engaging policymakers in modeling. However, there are always limitations to any model. Data quality and availability is always a challenge, and we're doing our best to try to document that by actually doing some primary data collection and simplifications of the impact of human resources, information systems, and budget was necessary in order to have this model be completed and run. And those will be some of the limitations. The model updates will require further data, which could challenge sustainability. But we're actually at least attempting to start with data collection. So it should be more relevant upfront. And there is uncertain uptake of policy recommendations, but what we've done is to try to at least incorporate the leaders from the Ministry of Health at this point. Our next steps with modeling is to identify critical variables for optimization, and we're doing some AI-powered searching to understand what other literature there may be around some of the variables that we need to gather. And then we're going to finalize the model and key assumptions in the model as well, and train it. We're using Python to build this model so that it will be open access. And we're designing intervention strategies that we will simulate within the model and look for different interventions that may be better in optimizing the supply chain. And we'll then actually suggest which interventions to carry out in the real world by implementing the interventions. So that's what we're trying to do in the modeling side, and I'll then pass it back to Atalay to talk about the South-to-South collaboration.
Thank you so much, Professor Sachi. So regarding our aim 3, our last aim, regarding South-South collaboration. Our initial thing is like capacity building in terms of modeling was one of our primary aim. And then we conducted the first round training. We invited 5 different African countries, so from Tanzania, Malawi, Botswana, Uganda, and Rwanda. Of course, from Ethiopia, the Ethiopian Ministry of Health, the Ethiopian Public Health Institute, and the Amara Public Health Institute participants took actually the capacity building training, first round capacity building training. We covered the health technology assessment and then data science and modeling. And then the experts were from University of North Carolina, of course, Professor Sachi and Dr. Shian. And then the health technology assessment part was covered by an expert from the Canadian Ministry of Health. And then we successfully completed this first round capacity building training, and the reception was really huge. So after this capacity building training, we established a consortium of 7 South countries and 1 North country, of course, USA. So right now we already established this consortium, and then even we start applying different projects to at least standardize and then improve the supply chain of specific countries. So here we didn't include South Sudan from the beginning, but recently we found out that in the South Sudan is going to be, can be taken as one of, for example, in terms of the worst case scenario. At least South Sudan doesn't have a very strong supply chain system as per the evidence we got. So if you include South Sudan, probably you can take or can learn lessons from both South Sudan. They can learn lessons from other countries. So that was the whole idea. And then we submitted one big grant. Still, we are waiting for that. So probably this consortium was officially launched and then established. And then the other is like networking with other modeling universities or institutions like APHRC in Kenya. We had an experience sharing with them. And then in addition, we are also continuously engaging the modeling of disease and health in Africa, the MODHA network. We participated recently organized conference in Kenya, Nairobi. So this was continued. We have also continuously engaged in a monthly their monthly progress update. So and then recently, like a month back, we presented our progress update to the MODHA network group. And then in addition, we are from the beginning, our project was we are engaging the Ministry of Health, and then we are still continuing engaging the Ministry of Health's different departments, like the strategic affairs of Ethiopian Ministry of Health. That's the one that's responsible for aligning different projects with the existing strategies of the Ethiopian Ministry of Health. So we presented our project aims, and then we are just trying to align our projects with other already funded projects. And then in addition, we had also a monthly check-in meeting that's organized by the Gates Foundation. So all the Gates funded projects have a monthly check-in meeting so that we can at least minimize duplication of effort and then maximize alignment of our project aims and then agendas. And then in addition, we have also a continuous progress update and then moving forward meeting with the Ethiopian Ministry of Health, of course, our collaborator, the Primary Healthcare Lead Executive Office, as well as pharmaceutical and medical device, medical equipment Lead Executive Office. And then in addition, recently, the Ethiopian Ministry of Health, one of the office, organizes the National Supply Chain Donors and Implementers Forum. And then we presented our project. The whole point here is at least to minimize the duplications of effort and then better align, each and every project with the existing Ministry of Health strategies or initiatives. So our next step is to we will conduct our second round capacity building training. So during our second round capacity building training, we will use our own modeling as well as data to train participants. And then we will for sure strengthen our modeling network and health technology assessment related activities of the different actors. And then our project is actually ending in June 30, 2029. As I have said, like we are almost at the end of year 2. So far, so good. We are progressing well, except some like modeling related training and calibration issues are still ongoing. I believe, I'm sure we'll make it happen as per the timeline. So in conclusion, so our need assessment shows there is still a huge supply chain gaps. And then we believe that the modeling and simulation probably will address the issues, and then probably will end up with generating high level policy inputs and then interventions. And then we'll, of course, strengthen our South-South collaboration, given that, we can, learn from others, and then others can also learn from our experience. So finally, I would like to thank the Gates Foundation for funding our project. Of course, the collaborators, including the African Population and Health Center Health Research Center, APHRC, and then AMREF Health Africa. Their contribution was enormous, particularly during the initial phase of the project. So thank you so much. If you have any comments, you are welcome.
Thank you. Thank you so much, Atalay and Sachiko, for that. So what I'd like to, just some reflections. One, of course, I think this is really reflective of what we want to see in health systems modeling. You have a problem that is clearly felt. You had policymakers involved throughout, and you've seen how you engage them throughout. You brought some methodological innovation, bringing together agent-based and system dynamic modeling. You're looking at health and economic impacts together of interventions, and there's capacity strengthening and South-South collaboration. So all in all, very interesting. It remains to be seen, of course, you're still quite early in the process. But overall, this is really a very interesting piece of work to reflect on. So I'd like to now have open it for the question and answer panel discussion, which we'll be posing questions to you, Atalay, and Sachiko. Unfortunately, Dr. Israel Atoro isn't here. And I'd like to introduce Professor Tim Robertson, who will be co-moderating this with me. Tim Robertson is an associate professor at the University of Western Australia, and he is leading the technical and modeling aspects for the Health System Impact Modeling Consortium. So we'll begin the questions. Tim, over to you for the first question.
Thanks very much, Zubin. So maybe a question first to Atalay. At the start of your presentation, you showed us a lot of data from the quantitative and qualitative work you've done or others have done, including data on the availability of medicines, stockouts, and other sort of data related to the supply chain. When you build your model, or as you're building your model now, are you able to make use of all of that data? Like, is it able to be put into the model? Or is it at least informing, or how is it informing your model in other ways, maybe assumptions or understanding what to look at, et cetera, et cetera. So yeah, just if you could talk about the link between the data that you have, that you showed us, and then how that's informing your model.
Yeah, thank you so much, Professor Tim. That's a very good question. So, of course, like the main reason why we conducted the baseline assessment or studies, like to define the model actors, like which parameters are going to be considered in our modeling assumption, how best we can train our model, because probably our initial model may not be perfect. So how can we best calibrate our model, at least to show the real world data? So and so lots of actually things can be like reflected. So all in one, the main reason why we did our baseline assessment was, as Professor Sachi mentioned, using the real world data or actual data is preferred in terms of the agent-based modeling or system dynamics modeling, because it will give you more flexibilities to calibrate, modify, and then even adjust the parameters accordingly. I hope I addressed your question. You are on mute, Professor Tim.
Thank you for that. For that response, Atalay. My question is now to Sachiko, and just given the limitations highlighted from the presentation, particularly those around data quality, availability, and the need for regular updates, how is the team thinking about calibration, validity, and uncertainty so that policymakers can interpret the results with appropriate confidence? We don't want to, of course, appear giving this as a magic bullet and that you got the answer. So how do you balance the need their need for precision and the questions you have around these quality, availability, and uncertainty?
Yeah, that's a great question. So validity, I think we're getting a lot of that from the surveys and the data that we're collecting. And we're also, in addition to collecting some of those inputs, we're collecting data that we may be able to use to calibrate. And so validation, calibration, a lot of that will be done by triangulating the different data that we're collecting through the surveys. And then the sensitivity analysis would obviously be conducted in order to get at the uncertainty range. And we will do our best to run probabilistic sensitivity analysis to range the most important variables to understand how much the data inputs are actually affecting the final outcomes. And that way, we'll also know what the value of information would be for certain variables and which ones we really need to keep an eye out on to make sure that we have good, valuable data going into the model in the future.
Thank you. Thank you so much, Sachiko. My next question is to Atalay. I just want to understand how the engagement of the Ministry of Health, regional actors, and other stakeholders have shaped the modeling so far. And do you have concrete examples of where policy dialogue changed the model structure, priority questions, or intervention scenarios being tested?
Yeah, thanks so much, Zubin, for that good question. I think everyone can learn from us, from our process. So what we did was from the beginning, our project involved the Ethiopian Ministry of Health, policymakers in general, and then specifically the departments that are responsible for handling the primary healthcare needs. So we're continuously engaging them, receiving feedback from them, and then modify and then align our initiatives as per their need. So to mention few things, for example, initially as an outcome, availability as well as wastage rate were our outcome variables to be considered in our modeling assumption. But recently, I think there is a direction that leakage is also becoming a problem in terms of like supply chain. So they recommended us to include the leakage rate in our modeling assumption, like how based this optimization process will reduce leakage. So diversion to other countries, like neighboring countries, or even diversion from the facilities to the primary healthcare center. Other, in outside of actually the primary healthcare units. So all these recommendations were captured, and then we are going to include this additional variable as an outcome. And the second one is through engagement, we found out that there is one funded project that's closely working with the Ethiopian Ministry of Health to standardize the forecasting activities. So there is one tool called OPIAN forecasting tool. And then, honestly speaking, we have no idea before that, but we found out that this OPIAN forecasting tool is going to be implemented across the healthcare continuum. So initially, one of the problem was like forecasting and quantification is a major issue throughout. So if we probably include how the OPIAN forecasting tool improves like availability, wastage, as well as leakage issues, then means like we can probably like test the impact of this OPIAN forecasting tool on the availability as well as wastage of medicines in the primary healthcare unit. So that's also like a new addition for us. So now I know we are closely working with the OPIAN forecasting tool developers. So probably once it's implemented, we will study its real impact on the availability of medicines. And then the third is recently, I think a year back, the Ethiopian Pharmaceutical Supply Services implemented the Committed Demand Initiative because of actually like different issues. Initially, like facilities are continuously reflecting that the fill rate by EPSS or the government procurement agency is very low. And then the Ethiopian Pharmaceutical Supply Service or the government procurement agencies frequently reporting or telling us that they are significantly facing expiry of medicines because the facilities, facilities are not taking the forecasted quantities that was reported to EPSS, and then EPSS is actually procuring medicines based on the forecasted quantity by healthcare facilities. But actually, after EPSS procures those medicines, facilities are not actually taking this medicine. So as a result, the government procurement agency recently developed a committed demand policy that every forecasted quantity is going to be taken by the facility. Otherwise, like this is a legal binding that they have to be always like mindful in sending forecasted quantities, something like that. Means like they are really committed. If they fail to take that particular medicine, so it's going to be a legal issue. So we will see how this committed demand initiative impact the availability as well as wastage of medicines. So yeah, these are actually a few things to mention.
Great, thanks very much. So one last question maybe for Sachi, and then we'll open it up for the audience questions. So if you want to put your questions in the chat or the questions Q&A, I think we've already had a couple, then we can try to moderate those and ask those after this. But in the meantime, so Sachiko, in my experience, it takes quite a bit of capacity to build these sort of models. And the model you talked about, agent-based model, systems dynamic modeling, is not easy. And it does require some like understanding of these tools, models, etc., and how to run it, even how to kind of update and maintain it if it's already been built. So I know you're sort of at the outset of the project, but are you thinking about building this as a tool that will then be handed over? And if so, are you doing any work now to kind of build it in that way? Or is the plan just to sort of get the model running so that you can perform these analyses and then, not necessarily leave a tool for use? And I ask that because in my experience, it's quite hard to sustain these tools over time if the initial modeling team has sort of left or moved on. So yeah, just wondering how you're thinking about all of that. Thanks.
Yeah, so I'm serving more as a consultant than the actual modeler. And I think that's really important in these kind of contexts, so that the local modelers are really able to get down and dirty into the modeling, build it, and be able to continuously train others. So we're doing a lot of capacity building on the ground with the modelers and trying to build that team locally so that it can sustain. And so that's our approach here. And I think it's really important that the high-income country doesn't fly in and build it. We need to really be on the capacity building and modeling support side.
Great. And maybe just while we're on that, so Atalay, then from your perspective, is there appetite for building this tool as a tool or resource in the long term, or is it at the moment it's just building it to get an initial analysis going?
Professor Tim, can you please repeat? Sorry.
No, I'm just curious, are you building this model now as to complete a kind of initial analysis, or are you building this as a tool that you will be able to maybe still use in 5 years, in 10 years' time?
Yeah, so our plan is, yes, we are start like developing the model, training the model, calibrating it accordingly. So the plan is, because the implementation is purely led by the Ethiopian Ministry of Health. So we believe this is going to be still implemented and then utilized for whatever time is allowed, and then so long as it's accepted by the Ethiopian Ministry of Health, so it's going to be implemented and then applied till the better maybe assumptions came in. That's our thinking from the beginning.
Okay, we have some questions from the audience, and I just honing on one around. There's a question around workforce. So, have you seen in your model the workforce part in terms of national staffing for supply chains? So, I've been involved in health systems modeling where it's pretty much very workforce dominant, and a lot of it is around understanding the role of the workforce, recruitment, production of workers. Performance, supervision, etc. Your model, I think, is explicitly about the supply chain, but I'm wondering, to what extent are you going to have elements of either the workforce or other health systems building blocks sort of brought into this, or are you kind of ring fencing it as a supply chain model?
Yeah, great question.
Go ahead.
Go ahead, Atalay.
Yeah, no, go ahead.
Yeah, I think we're primarily kind of focused on the supply chain through that agent-based model on the medicines, but we are using the information systems, the human resources, and financing as those building blocks that would influence the supply chain. And those are the system dynamics part that we're kind of incorporating. And so it will have, it's not that those parts will be more on an aggregate and not as detail oriented, because it's really hard to build everything with a lot of detail, right?
Yeah,
and get it to
sure.
work and run. So that's how we've focused it. So we're incorporating the other building blocks while kind of simplifying those, and then really focusing a lot of our efforts on the medication supply chain.
Great. This gives me a tiny window to ask you another question, so Sachi, about your experiences. So, the people who are listening in might be familiar with agent-based modeling, might also be familiar with systems dynamics modeling. You just touched on then, you said, okay, if I understand it, the more systems things are going to be the systems dynamics, and then agent-based maybe for the supply chain. Can you just, and please educate me as well on this, why are you choosing one versus the other for these different things? Is it purely around the data, like you have individual level data for some and not for others? Is it about complexity? Is it about some other characteristic of these types of modeling approaches that are good for different purposes?
Yeah, great question. So there aren't that many hybrid models out there yet, and I think there's some new technology that could be utilized here. So agent-based models are really good at getting heterogeneity, right? And it's also really good at learning and adaptation and looking at simulations that can change rules over time and simulate what actually happens. And we really wanted to use this. The agent-based model for the supply chain, because it has that flexibility. It does require more data, which is why we're doing a lot of data collection. We talked about the 25 tracer medicines in 56 primary healthcare facilities. So that's the kind of data we need to get that part to build. But we wanted to simplify the rest because we can't collect everything at that level. And so the information systems, the HR and the financing, a lot of those are going to be on the system dynamics, which are more on an aggregate stock and flow And we are going to set it up so that those toxin flows will then influence the agents, right? And then have that relationship between the system dynamics and the agent-based model. So that's how we're trying to build this model.
Great. Just if I can, do they, when you run the model, do they interact? Are they running at the same time, like systems dynamic runs for 1 year, then that informs agent-based, then it goes back, or are they sort of run independently?
Yeah, they would be interacting with one another. Yeah, it's definitely possible to set it up that way. And now that we have AI technology, I think it's getting easier to actually build models. And we wanted to set it up so that you're kind of taking advantage of the different strengths of different models. Yep. And the goal is to get it to interact. Yep.
Yeah, no, that's great. I as someone who's using AI on a daily or hourly basis to code and build tools, I know what you're saying. It is, I feel like the ability to manage complexity in a kind of software tool or a thing is becoming easier, with risks, and I think we're learning how to do that. But it does seem that we could use AI to wrangle or wrestle the kind of incomplexity of a kind of a model like this. So, still allowing, hopefully, for the possibility of interrogating it and understanding it, but actually doing the engineering of the model itself is now, I think, a lot easier if you know how to use these tools. There's another question in the chat about, well, let me just say the one on the emergency health situation that often disrupts the system. So, as you're building this model, is there any kind of explicit understanding of health system shocks, conflict, other kind of potential disruptions may come? Atalay, do you want to answer
that? Yeah, Professor Sachi will add. So for sure it's going to be taken as, one scenario, like what if we end up with like budget constraint? What if we end up with some sort of like COVID pandemic? So such assumptions will be considered in our modeling and simulation activity. The thing is going to be like, still we are going to be dependent on secondary data and not, So yeah, for sure it's going to be taken as one assumption.
Okay, great. Good. That's great. Imagine if you're building a model, you can then use that in many different ways to model different realities. So that's great. Let's try to get to the third and final question that I see here in the Q&A, which is from Bonventure. This, I think, if I understand the question right, the question is, so, the qualitative research that you did found, certain operational challenges that I suppose on the more kind of human managerial side, perhaps, or process kind of, side of things. When you do a quantitative model, it's very hard to, correct me if I'm wrong, it's hard to sometimes capture those more kind of upstream human management type considerations in a model. So, and oftentimes they could end up being the actual bottleneck, right, to supply chain functioning. So maybe you could tell us how far upstream do you think, or to what extent do you think you can capture that in your model?
Yeah, so let me add a few points, and then probably Professor Sachi can also add. So our assumption is not like in the primary healthcare unit. So probably if you look at the upstream lead time, so that upstream lead time might be because of different operational factors. For example, there might be a delay in supplying, like manufacturers might need some time to supply products. So our assumption actually starts from the actual manufacturer, how long it takes like to supply products to EPCs, for example. Is it 1 year, is it 3 months, or is it 1 month? And then we'll consider actually such efficiencies indirectly through the lead time, or actually like time sensitive components. And then from that, still the different actors are also involved, like banks are involved, because our country is like fully import dependent. Still, the local manufacturer are, addressing very limited, like not more than, probably like the reports are saying up to 30%, but I still have a doubt on that arena as well. And then the customs clearance. So customs are really also one factor, like in dealing of actually like product supply or access. And then the other is like transport service providers. Like still we are landlocked country, so still we are using two modalities, either air shipment or sea shipment. So we know that air shipment is more efficient in terms of getting it timely. The sea shipment is a time-taking process. So for sea shipment, there are also like companies that provide transportation service, inland transportation. And then there's also regulatory authority. The regulatory authority has to also oversee and then approve the product. So this is when we look at actually like the upstream components. So each will have impact on, properly or the efficiency of the supply chain system. So that's why, like, the system dynamics concepts came in. So we can't address, this issue, this very complex issue, with multiple different actors with agent-based modeling. So we believe that we will also try to catch the operational factors or determinants. This is, I guess, actually to mention few. Even within the healthcare facility, there are also different factors. So we have to get approval in terms of finance, to procure, and then you have to also get approval to book orders, and then there are also like still road access issues, and then of course information system related issues, workforce related problems. So those things will be probably will take into consideration in our modeling assumption. Yeah.
All right. Zubin, I think you're going to ask a question now, maybe.
Yeah, sorry, I was on mute.
Yeah. Yes.
Yeah.
Okay.
So, what do you think the MOH sees as the utility of a modeling exercise such as the WISE project? And how do you think it can realistically, there's always uncertainty about this, of course, of how it's going to actually work. And that's not what we researchers can actually do. But what do you think would be the practical application of this? And how do you think they'd be able to use this? What would be your best guess?
Professor Sachiko?
You don't want to take that, Atalay? I think the optimization and the different interventions that we're testing, I think is the real meat of this. So trying to figure out, how can we optimize this through different policies and simulating this. And kind of ranking them, right? To say like this policy is probably better than that policy. And then actually deciding which intervention would be most relevant in country and actually implementing it. So that, and actually seeing whether, if we implement it, does it look like what we simulated in the model? So I think those are the different pieces that we're really kind of testing out through the model, so that, the model allows us to run a bunch of different policies at the same time without actually doing it in reality. And that's the benefit of modeling. So then we can prioritize which policies to go with, actually conduct it in reality, and see whether or not the model was informative, and hopefully it is, and that they can continue to use this in the future to see what other ways in which they can use, optimization policies after implementing one. There may be additional ones that they can implement. So that's the idea.
Thanks a lot. So I hand over to Tim now for closing reflections.
Yeah, I think we're at our time now, so I think we're going to close. But I just wanted to say a big thank you to Atalay and to Sachiko for coming and presenting. I think by what you've shown us is you're still at the outset of this exercise, and but it's it's really exciting. I think it shows a real thoughtfulness to how you're going to build it, and not only how you're going to build it, but how you're going to embed it in the country, and then also add on the South-to-South collaboration, which I think is rare but really an exciting part of it too. I hope we can get you back in 2 years to see how it's all gone, and we'll look forward to reading the findings of the model in whatever form you can share. It's certainly like I have not done much supply chain modeling myself, so I would be really curious to see dig into it when you do it. And yeah, wish you all the best for doing it. Hope you can surmount the challenges that you mentioned, and it's sure to be, I think, of real benefit to the country and the benefit for all of us who are trying to figure out how to do this and learn from each other. So yeah, thank you. I think with that we can just close, and thank you to everyone for attending. We're going to be having probably 1 or 2 more of these by the end of the year, and so if you hear about it in the same place that you heard about this, and we look forward to having you all back for our next conversation. Thanks very much.
Thank you so much for having us.
Thank you so much, Professor Tim Zubin, Professor Sachi, and Vicky, everyone here. So it's really, a pleasure being here and then sharing our experience. We received actually very helpful questions from you both. I mean, from you all. So we are really happy and then really appreciate it.
No problem. Great. All right. Thank you very much. Thanks, guys. We'll see you later. Bye-bye.
Thank you. Have a good day.
Bye.